Good morning. Can you hear me?
Yes.
Good. My talk today is really packed. It's adolescent-onset borderline personality disorder, psychosocial functioning, treatment histories, phenomenology, better known as symptoms, co-occurring disorders, and the etiologic factors. Now, there have been earlier studies of BPD in adolescents, and I'll just highlight two. David Bernstein, in 1993, working in the Children in the Community study, documented that adolescents do meet criteria for BPD, and that was an important discovery, and that's almost 20 years ago. Carlos Grillo from Yale led a group that in 1998 and many other times have found that about equal percentages of hospitalized adolescents and adults meet DSM criteria for BPD. Now, I've been in this field a long time, and when I started, BPD for adults was not considered a valid disorder. It is now. And all of my talk is to basically show you the similarities between adolescents and adults with BPD, and to let you know that in youngsters, 13 to 17, it is definitely a disorder, and I think a valid disorder. So let's begin. Now, the purpose of this study is to compare 111 inpatients with adolescent-onset BPD to 224 inpatients with adult-onset BPD on the 5 parameters I've just mentioned: their psychosocial functioning, their treatment histories, their phenomenology or symptoms, their co-occurring disorders, and etiologic factors. Now, what is adolescent versus adult-onset BPD? It's determined roughly for this study by the age of the first hospitalization. Adolescent onset would be less than 18, or boys and girls 13 to 17 at study entry, and adult onset would be 18 and older, or men and women 18 to 35 at study entry. Now, our adolescent sample is from the McLean Mount Sinai study of child and adolescent development, or MSCAD, and my co-investigator at Mount Sinai is Marianne Goodman. And our adult sample comes from my own McLean study of adult development, or MSAD. This is an NIMH-funded study of the long-term course of BPD that's actually now in its 20th year. And what we've found over time is that BPD is a good prognosis disorder symptomatically. Remissions are extremely common. We have a paper coming out in the April American Journal of Psychiatry showing that after 16 years of prospective follow-up, 99% of borderline patients will have attained a stable remission of at least 2 years or more. And recurrences are relatively rare, as are suicides, compared to the expected rate of 10%. Even after 16 years, it's less than 5%. However, there are some more guarded areas of the prognosis of BPD, and that's psychosocially and in terms of physical health. Only about a half of borderline patients are able to work consistently and competently, and some of that's due to the way our entire healthcare system is paid for. Many people go on disability in order to get Medicare and Medicaid, and if they were separated, we might have less psychosocial disability, or there might be less apparent psychosocial disability. The other thing, which is, I think, iatrogenic in nature, is about a third suffer from obesity and obesity-related illnesses. And in my own patients, I've seen people pick up 40 pounds in 6 weeks as they start medications, and it's not a minor matter. Obesity is a risk factor for many other serious conditions, and we all only have one body. Our brain and our mind exist within it, and we need to pay attention to it. Now, our subjects were 111 adolescents meeting DIBR and DSM-4 criteria for BPD, and I'll explain what the DIBR is, and it takes away this problem of the 256 combinations. And 224 adults meeting DIBR and DSM-3R criteria for BPD. We did drop 66 MCAD subjects out of our 290, or about 20-25%, who were first hospitalized before the age of 18. So we have purely adult onset versus purely adolescent onset. Now, what is the DIBR? John Gunderson in the 1970s developed an instrument called the Diagnostic Interview for Borderlines, and in an act of generosity and perhaps folly, when I was a postdoc, he allowed me to revise it. And basically it has 4 sections. We study affect, cognition, impulsivity, and interpersonal relationships, and you must have symptoms from all 4 sectors simultaneously. and it results in a somewhat smaller and quite a bit more homogeneous group of borderline patients or subjects. One borderline looks very much like the next. Now demographically, here we go comparing the borderline adolescents to the borderline adults. Not surprisingly, the adolescents are younger. They come from the same social class on average. Their general functioning as measured by their GAF score is lower. They're more likely to be female, and they're more likely in this mixed sample to be non-white, and that's because of the participation of Mount Sinai Hospital, where we did join with them to get a broader range of people. In terms of psychosocial functioning, as you can see right down the board, the adolescents are still functioning better than the adults. And I think that's because they're still receiving support, emotional support from their family and the larger community schools and many other options that are open to adolescents that are not open to adults. They're twice as likely to have a good relationship, report a good relationship with their mother, and where at baseline many adults describe their parents very negatively, many of the young women and men in this study describe their mother as their BFF, which is certainly a change. There's a substantial difference in borderline adolescents reporting they have a good relationship with their father, and a good relationship means it's free of neglect and abuse and conflict, that basically it's supportive. It's something they can count on. They're much more likely to report having good relationships with friends, almost 90% to about 50%. They even report they're more likely to have a good relationship with their romantic partner, even given their young age. And that's about half to a third. And then good work and school performance, this is the one that concerns me the most. Basically 70% to about a third. And this is an area where I've suggested for adults, we need to look to a rehabilitation model to really get over this psychosocial impairment in the world of work. Let's look at their outpatient treatment histories. They're equally likely to have individual therapy before their index hospitalization. In fact, it's just about everybody. Standing medications, the borderline adolescents are more likely to have been medicated than the borderline adults. And I think that's because some of the young adults in the MSAD study got in the hospital in a way that was surprising to them. They complained to their boyfriend of being suicidal. He took them to the health service, the ambulance was called, and they arrived at McLean's. They didn't have a chance to be on meds. Aggressive polypharmacy, this is a really concerning one and it links to obesity. This is 4 or more concurrent standing medications. And as you can see, it's 15% in the adolescents versus 47% in the adults. And these cocktails of meds, which by the way have no proven efficacy, really do lead to obesity. It's almost impossible to avoid awakening when you're taking these things. In fact, our group is the only group ever to have studied in a randomized trial of monotherapy versus polypharmacy in borderlines, and the monotherapy worked just as well. Family therapy, there's no difference. 30 to 40% have been in family therapy. Now, history of more restrictive treatments, psychiatric hospitalizations. Borderline adolescents were more likely to report prior hospitalizations prior to their index admission. They were less likely to report residential programs. They were also less likely to report being in day treatment. And I think that what you see in the residential programs, and which are halfway houses and day treatment, really are some of the borderline patients becoming chronic at a young age. In fact, for us, if you're 25 or younger as an adult, you stand a very good chance of having a full life, the life you've dreamed of. If you're already surprisingly as young as 26, you may be on a more problematic course. Now, rates of early onset axis 1 disorders. If I had just taken the rates at study entry of the adolescents and the adults would have had more of everything. So what we did is, because we had the age of onset of all of these disorders, we compared them. These are both adolescent onset rates of axis 1 disorders. And as you can see, there are no differences for substance abuse or PTSD, but there is for major depression. Borderline adolescents are almost twice as likely to report a history of major depression as they enter the hospital. And here we can see The same story for panic disorder, where it's 25% versus 5%, social phobia, where it's 23 versus 10, and EdNOS, which is primarily some subthreshold bulimia or anorexia, and some little bit of binge eating disorder, 25% to 9%. So while the adolescents are functioning better psychosocially, axis 1, they have a good deal more going on, and this makes sense, that as their borderline disorder kicks in earlier, so do their axis 1 disorders. Now, these are our BPD symptoms that were studied. We studied 22 symptoms in the DIB-R and 2 DSM symptoms not assessed in our measure of affective instability and serious identity disturbance. So we studied 24 symptoms, not 9. And let me take you through these. You'll see 12 things that are listed as being significant differences. Only pay attention to the ones in bold. The others are really a statistical artifact. When you get 2 groups that both start to approach 100%, you get a significant difference that is clinically meaningless. But there is no difference in the groups with chronic or major depression. So major depression or dysthymia, almost everybody reports them in the past 2 years. Chronic feelings of helplessness and hopelessness. The BPD adults report it more often, but it's such a small difference, it's not clinically significant. No difference in anger. About 94% of the people say they're angry a lot of the time when they engage in angry acts. Anxiety, there's no difference, 90% or more. And again, way more than 90% chronic feelings of loneliness and emptiness, with the BPD adults, again, being a few points more likely to report it than BPD adolescents. So affectively, the groups really are the same. And you can see the rates are phenomenally high. Almost everybody reports each of these symptoms. Cognitive symptoms, odd thinking, and for example, the best example of odd thinking in this sample would be overvalued ideas. I'm ugly, stupid, fat, bad. I caused my abuse history. Unusual perceptual experiences would be experiences of depersonalization and derealization. And here you can see the adults are significantly more likely than the adolescents, 88% to 79%. No difference in non-delusional paranoia, and the best example would be ideas of reference. But with quasi-psychotic thought, and these are circumscribed, time-limited, and somewhat reality-based delusions and hallucinations which have nothing to do with schizophrenia. They're not bizarre at all. They don't dominate people's lives. You can see this is the first truly significant difference, 53% versus 30%. People with adult-onset BPD reporting it more likely than people with adolescent-onset BPD. Substance abuse, you can see for the impulsive symptoms, substance abuse is absolutely no difference. Sexual deviance, which is mostly promiscuity, there's no difference. Self-harm, there's no difference. Manipulative suicide efforts, there's no difference. And manipulative shouldn't have been used here. It's really help-seeking suicide efforts. It's a wish to be helped rather than necessarily a serious wish to die. And this encompasses suicide threats and attempts. And other impulsive patterns, which could be disordered eating, reckless driving, temper outbursts. And you can see that all of these things are extremely common, and around 80% or more of the people engaged in self-harm and suicidality. Now, the interpersonal symptoms are where we start to see differences that count, and we'll talk about the reasons for that. Intolerance of aloneness. People with adult-onset BPD are significantly more likely to report intolerance of aloneness, 94 to 84%. Abandonment, engulfment, and annihilation concerns, which the person can report themselves. Again, a significant difference in favor of the adults, 93 versus 81%. There's a difference that's significant, but not in a major way that's clinically meaningful, for being counter-dependent or serious conflict over health care. Stormy relationships, there is no difference, and this is in our more simplistic and less complicated way than DSM is yelling, screaming, breaking up with people. And dependency, undue dependency, masochism, or letting other people hurt you. 92 versus 70%. One of the greatest differences, the adults are much more likely to, or the people with adult onset BPD, to endorse this than adolescents. Now, the next one is devaluation, manipulation, sadism, known as cruelty. And this is another one that's much more common in those with adult onset BPD than adolescent onset BPD, 86% to 65%. And let me just say, because this was a conversation I was listening to as I drove back into the White Plains last night, these things, devaluation, manipulation, sadism, demandingness, entitlement, are seen as horrible things to call other people. I've been using these terms for 25 years. To me, they're simply outmoded survival strategies, things people do to express their distress. They're awkward, but they're not things that are forms of misbehavior. And I think we should have no judgments about them, because the fact is we're all a little bit all of these things. And people want to say, oh gee, that's the patients, it's not me, as they're manipulating you to do coverage for them. So I wouldn't take these things personally, they're terms. Being demanding and entitled, not a major significance in terms of the difference, 60% versus 46. Treatment regressions, getting much sicker in treatment, having treatment to almost be toxic, 45% to 40% again, and basically an equal percent. But here, a major difference, 46% to 14%, counter-transference problems or special treatment relationships. This may be due to the fact that the adults were assessed 20 years ago, and the adolescents have been assessed in the last couple of years. And I think people have learned much more about how to handle people with BPD and are much less likely to get themselves into trouble with these patients for temporary outbursts or inappropriate closeness. Now, the DSM symptoms, neither of them are our major differentiators. Affective instability, almost identical percents, 90 versus 74. And serious identity disturbance, a minor difference that's significant but without clinical meaning, 76 versus 63. And let's go on to summarize the symptomatic findings. 12 of the 24 symptoms of BPD we've studied were significantly more common among those with adult onset BPD than those with adolescent onset BPD. As I mentioned, however, only 6 of these symptoms remain significant at the more stringent on-phony corrected level of probably less than 0.002. And interestingly enough, the ones cognitive, quasi-psychotic thought, and all the rest are interpersonal in nature. Intolerance of aloneness, abandonment concerns, undue dependency or masochism, evaluation, manipulation, sadism, counter-transference problems, special relationships. As I basically mentioned before, there were no significant difference found for affective or behavioral symptoms, 1 cognitive symptom, and 5 interpersonal symptoms. And just a word about these theories and sort of the in-house fighting over which is the core symptom of BPD. Many people believe it's the affective instability or reactivity, which is regulation. Other people, John Benderson believes it's interpersonal hypersensitivity. Paul Links has suggested it's being impulsive. I think all of these 4 symptom areas are necessary for the diagnosis, and they cascade together in different ways for different people, even the same person at different times. Somebody could have an interpersonal slight from their boyfriend, they become upset, then they become a bit suspicious of other people, then they start fighting with other people, and they're different scenarios, but it's always the same 4 areas. And which one is core? It seems to me, and perhaps I'm alone in believing this in this room of experts, it's almost a matter of religious belief rather than any empirical support, because who could know? Because it would be different for the same person at different times. It's a moving target and involves a cascading effect. Now, childhood adversity. Reported history of childhood sexual abuse. This is really interesting. Of those with adolescent onset BPD is 20%, and for the adults, it's almost 60%. And all of these differences are clinically meaningful. I think the reasons for this, 20 years ago, when the adults entered the study, and they were children 15 years or more before that, I don't think our society knew as much about abuse and things were going on that people just didn't know about, and children were left to struggle with on their own. The kids with adolescent-onset BPD now, their parents are much more protective. They know that this is a real danger, and they know that the friendly neighbor down the street, he should not actually be having a child over every afternoon to help him build a boat in his basement. It maybe works on the TV show NCIS, but it's nonsense in real life. In terms of the severity of other forms of abuse, emotional, verbal, physical, even these numbers are somewhat meaningless, but you can see that people with adult onset BPD report more severe childhood, other forms of abuse in the adolescents. And the adults also report more severe neglect. And this neglect was not just physical neglect, it was all of the ways the parents who were doing their very best may end up making their child or leading their child to feeling neglected. It could be that they're depressed, and so their child feels them withdrawing, and we count that as a form of neglect. Now, factors of normal personality, these are T-scores, so about 50 is an average number. Basically what this says is the adolescents report that they're less neurotic than the adults, they're more outgoing. Openness, which is an appreciation for aesthetics, not something adolescents are typically very good at. It's exactly the same and totally normal with the general population, that they're less agreeable and less conscientiousness, which is pretty normal for adolescents. And the reason I'm presenting this right after the adversity is there really potentially are two types of borderline patients, or maybe there's an interaction effect. In the adults at McLean, we sort of see adult borderlines who are thought of as trauma borderlines. Their histories were so grim that the most salient etiologic factor is their childhood adversity. I personally believe you cannot get BPD just through adversity. You have to have a vulnerable temperament. And then there's a kindling event. And that kindling event can be something as normative as going off to college, so you don't have the support you ordinarily did. Or it could be something catastrophic, like being date raped at college. But I do think more and more will look at temperament as the core feature, the core underlying feature of BPD. And temperament, personality, is biologically based. Each one of you in this room may have had a child or a sibling or yourself described either as an easy baby or a difficult baby. And while parents like to think, you know, difficult one, not my problem, the easy one, I'm really a great parent, in fact, they just sort of come that way. And we just have to deal with that. Now I'm going to quickly review our main findings, but I really want to open this up to questions and discussion. Our first main finding is that those with adolescent-onset BPD reported better social and vocational functioning than those with adult-onset BPD. And as I mentioned before, perhaps that's due to the greater support adolescents often get from their families and the community in general. And the question is really going to be, what happens when they get older and the community and families provide less support? Will these people be able to work full-time? Will they be able to maintain good health? Our second main finding is that those with adolescent-onset BPD are less likely to have been treated with aggressive polypharmacy, which is good, and they're not as chronic, so they're not less likely to have been in a halfway house or in day treatment. They're more likely to have been treated with standing medications of some sort and have had prior psychiatric hospitalizations, and that's not so good. Our third main finding is that these findings suggest that those with adolescent onset and adult onset BPD exhibit very similar symptomatology, particularly in the affective and behavioral realms. Now this is important because NIMH is not interested in adolescent onset BPD. The people who work there are really overwhelmed with the number of applications from people studying childhood ADHD, childhood bipolarity. It's not so much they don't believe it exists, it's just not on their radar as an important thing. And yet when I think back of the adults I've treated with BPD, most of them started laboring in adolescence. They may not have become fully sick. In fact, in my MSAT study, the average age people reported they started to feel psychiatrically ill was 10, and the average age at which they got treatment for the first time was 18. And maybe if they hadn't been waiting around those 8 years, things would have gone a lot better. Possible reasons for these differences in terms of the interpersonal symptoms. Some of the interpersonal symptoms may simply not have developed yet in adolescence, and they may exhibit them later as they get older. And those with adolescent-onset BPD may not recognize the presence of some of these symptoms, particularly those of problematic interpersonal nature. We interviewed one parent for each adolescent, and the parents were more likely to report the interpersonal symptoms than the children were. And we're not sure which one was more accurate. It could also be that the adults had these things pounded into their heads by treaters, and the adolescents who were more gently treated, units like 3 East, different words are used so they don't recognize it in themselves. The next main finding is that those with adolescent-onset BPD were more likely to report early onset cases of major depression, panic disorder, social phobia, and EdD. But rates of substance abuse and PTSD were very similar. This certainly suggests that aggressive treatment of Axis I disorders in adolescents is really important, and not just to see this, oh, this is part of BPD. It may be a separate disorder that needs its own treatment. And that treatment doesn't have to be just medication. There are psychosocial treatments for these disorders. Our next main finding is that those with adolescent-onset BPD reported less childhood adversity than those with adult-onset BPD. As I mentioned, a lower percent reported childhood sexual abuse. In the adults, the sexual abuse was repeated. It was very serious, and in almost all cases involved penetration. And it just was very serious abuse. It was not one-time abuse. These people also reported less severe childhood histories of other forms of abuse and neglect. They seem to report that they were raised more gently than the adults. Those with adolescent-onset BPD reported lower levels of neuroticism, agreeableness, and conscientiousness than those with adolescent or adult-onset BPD. They also reported higher levels of extroversion. Extroversion isn't just being outgoing, it's having positive emotions. And whether this will sink under the weight of the disorders they get older, no one really can know. Now, directions for future research. We need to follow people with adolescent-onset BPD to determine if their course is the same as those with adult-onset BPD, which, as I've mentioned, is symptomatically excellent, but work-wise and health-wise, a bit more guarded. They might have a better prognosis as a core diagnosis was recognized earlier, and there are empirically based treatments for BPD, although they're not available to most youngsters or adults because of the expense of providing them, because they involve a lot of moving parts. And their prognosis, unfortunately, might be worse as they were first hospitalized before they assumed any adult responsibilities. And the sad fact is that in most psychiatric disorders, the younger you get it, the more guarded your prognosis is. But this may be a different kind of disorder. It's not as obviously biological as schizophrenia or bipolar I disorder. And I often think of the course of treatment with borderline patients is more like growing out of adolescence. It takes time. You can't hurry people along. You can't chide them into more mature behaviors, but once they get into adulthood, they sort of stay there. There's some people who regress back, but it takes a lot to get them to go back. And in some ways, I know that their remissions are far more stable and their achievements are far more a real part of them. Now, directions for another set of directions for future research. We need to develop treatments for adolescent-onset BPD, or at least determine if adult treatments work for this population. And I know Alex will be talking about that today. There's no doubt that DBT is the best research of empirically based treatment we have. We have 5 or 6 others now. We've got STEPS, which is an adjunctive group treatment, which I bring up because I think is cost effective. We've got psychiatric or general psychiatric management of Paul Links and John Gunderson, which is sort of psychodynamic attachment theory that the average clinician could practice. We've got transference-focused psychotherapy. We have mentalization of Anthony Bateman and Peter Fonagy, and schema-focused treatment as well. But all of these treatments are very expensive to provide except steps. And a new initiative of our group is we received NIMH funding to start an internet-based psychoeducation program for BPD. Everything you ever wanted to know about BPD, the curriculum and the assessments are all online. And the hope is that this pilot study, which will take 3 years, will lead to a successful outcome, and it will lead to a nationwide ability to access this program as a start. What we found when we studied 50 young women, 30 of whom were 18, 19 years old, were randomized to immediate psychoeducation, which was provided by research assistants, as opposed to 20 who were waitlisted, that they became significantly less stormy in their relationships and showed less general impulsivity. And that was with a 3 or 4 hour intervention. And I think those symptoms are the ones that went down because of the ones over which people have some control. And I also informed each of these 50 young women that they had BPD. And the study's quite a bit of time has passed. Even now at McLean, adults with BPD are often not told they have BPD. Or we have some miraculous experiences. I remember going to our short-term meeting with one of the doctors in charge who said, this woman will be appropriate for your study, just come into her bedroom with me. And she says to the woman, let's call her Susan, Susan, you know that trouble with your personality I've been telling you about? This doctor's going to want to study it. And the woman got tearful and she said to me when the doctor left, she had sort of thought I had a good personality disorder, but I was sick. Now she says even my personality stinks. And that took some time. But with the adolescents, the 18 to 19-year-olds, when I told them they had BPD and explained it's a disorder with symptoms in 4 areas and went through affective symptoms, cognitive, behavioral, interpersonal, good prognosis, all of them accepted it. Several became tearful. One asked to become a research assistant. And one said to me, oh, Dr. Zanarini, don't look so worried or so sad. Borderline, schmorderline, it's all the rage. So I think there really is hope for telling people about their disorder, telling them in an intelligent way, not mentioning their personality. That's nonsense. And there's no reason ethically why we would hide this disorder from patients, given the fact that it has such a good prognosis and the fact that there's so many treatments available to people. And as other people, Blaise and Alec have mentioned, the stigma for BPD exists mostly in our own hearts and minds, and if we could clear it out of clinicians' systems, I think this whole endeavor would go a lot better. Now, in conclusion, adolescent-onset BPD is symptomatically similar to adult-onset BPD. I have no doubt that you can have full-blown BPD as young as age 13. And I would assume if we down-age this, it would be true for even younger people. However, it does differ in other important ways that may have prognostic significance, the seeming psychosocial strengths, and the unfortunate greater prevalence of quite serious axis 1 disorders. So let me stop here and take your questions, and open this up to discussion.
Actually, have people, if they could write their questions down on the cards, and I'm trying to aggregate them so that into categories of questions. So have people written their questions down in cards? Give them a quick minute. So.
Start. I just had a question on, I looked in the cards, but on, you couldn't make out when you were giving examples of odd thinking.
I'm sorry, I couldn't hear you.
Could you give some more examples of odd thinking?
Yes.
You went through it quick.
Could you repeat the question, Mary?
Can I give examples of odd thinking? The most important one is the one I mentioned, which is overvalued ideas. And all that means is holding on to views about yourself that aren't true. And borderline patients will just volunteer that they're bad, or they're unattractive, or they're stupid, or they're evil, things that are definitely not true. There's some others, magical thinking, things like that, but overvalued ideas is the most common by far. It's also the most problematic because how do you go out for a job, or how do you feel confident about anything if your core beliefs about yourself, and these beliefs are what lay beneath the serious identity disturbances of borderline patients. In my mind, it's not that they're all over the place identity-wise, it's that they have such a negative identity about themselves.
You know, it's incredible. There's actually so many really fascinating questions, and I'm wondering if one of the things that we can do, as Mary brought to it, is that we can maybe put the questions up on the NEA BPD website and then have them answered if we can't get to all of them, because there's some really fascinating questions. So, for instance, one, Mary, can you say a little bit more about temperament and BPD?
Yes. About 20 years ago, I suggested that the temperament of borderline patients could best be seen as hyperbolic in nature. That when they're hurt, they don't let it just slide off their back. They're insistent and persistent in having others pay attention to their pain. And that's not uncommon. The difficulty is they do it in awkward ways because they're in so much pain, they haven't yet figured out a graceful way to express that pain. And in many ways, that's what our job is. It's not just to tamp down the symptoms, it's to help people find a more direct way of expressing them. I also think borderline patients suffer oftentimes a little bit of a language deficit. When you don't, as a treater or a parent, understand what they're saying, they often get very angry and feel that you're stupid and evil and mean. And patients will say things like, "You're a complete bitch." And my response will be, "Yes, I can see you for an extra hour this week." Because what they thought they were saying is, "I need more help," and it came out more like I should be going to, a federal pen for my failures.
Mary, can you talk a little bit about the genetics? Are people, are children of parents with borderline personality disorder more likely to develop borderline personality disorder?
I don't think that data exists yet. We have done family history studies where people tell you what runs in their families, and BPD does run in families according to patients. John Gunderson and I also have done the only family study where we actually asked the relatives, and it turned out that by their own self-report, BPD runs more strongly in the family, and all four core sectors of borderline psychopathology run more strongly in families. We were able to do some unbelievably sophisticated statistical analyses which seemed to show heritability. I'm not quite sure why. I thought we needed twin studies. But there is twin study data showing that BPD does again run in families, just like everything else in medicine. Doctors always say to you when you have a diagnosis, "Does anyone else in the family have this?" And not surprisingly, this is true too. I think without a kindling event, you wouldn't have a borderline patient. You'd have simply a vulnerable person. And there are lots of vulnerable people out there who, as long as life is gentle for them, will not develop BPD, although they carry this kind of temperamental vulnerability. And it's a vulnerability. It's not Huntington's. You're not destined to get it.
Could you talk a little bit about the difference between male and female borderline personality disorder?
That's a good question. Your chances of remitting whether you're a man or a woman are identical, so that's good news. Male borderline patients often in our mental health system end up in the criminal justice system, and there may be some petty criminality, but just as a vignette, when I was a trainee, I was talking to a young man who I was told was antisocial, and just on a hunch, I asked him about self-harm, and he lifted up his sweatshirt and showed me knife wounds in his chest, and he said, or his abdomen, he said, "Do you mean this?" And I said, "Well, how did you get those?" He said, "Well, I had a really stormy relationship with my girlfriend, and I've discovered that if I just stick the tip of a knife in, and I'm very careful not to hit any major organs or arteries, she's amazingly helpful. She calls 911, we ride in the ambulance together to Mass General, and then she's good to go for the next 6 months. And I thought, this guy is suffering from BPD more than APD, because a lot of the APD-ness of people with BPD is sort of minor adolescent stuff. It's class-based in a lot of poor neighborhoods. To do a lot of this kind of stuff, some minor stealing, lying, staying out late at night, is not the end of the Western world. It's just what's done in those neighborhoods. And I was much more concerned that this guy was sticking a hunting knife in his abdomen than that he might have, stolen some CDs out of a store.
There are a couple of questions about the cutoff for adult-onset borderline personality disorder, and how that measure was made, because even for a lot of those adults, maybe would have complained of symptoms, but just using hospitalization as the cutoff. So can you talk a little bit about maybe the artificiality about when the onset occurred, and whether it could have actually been diagnosed earlier on in their life?
I agree. It is an artificial cutoff. We decided to do it because to get into the hospital, you have to have full-blown BPD. You can't have a few symptoms here and there. And I think it starts earlier. There's no way with the adults of retrospectively knowing when they had full-blown BPD, so we relied on a standard measure, which is being hospitalized. We would really need to start an entirely new study to look at that issue and follow people really probably from early childhood who carry some particular vulnerability for this disorder forward through adolescence and into adulthood.
Two more questions. There are a lot of questions on treatment and treatment issues, and we're going to be discussing treatment later on, so I'm going to leave those questions until later. So, again, lots of other really excellent questions, and we'll try to post answers to them on the website. Can you just define EDNOS and SUDS?
SUDS is substance use disorders, and EDNOS or EDNOS is eating disorder not otherwise specified. It's subthreshold bulimia or anorexia, and it does include binge eating disorder.
Is there any current investigation into the association of sensory processing disorder and other neurological disorders and borderline personality disorder?
There may well be. I'm not particularly aware of them. The kind of language problems I was talking about with patients thinking they're being very articulate when in fact they're being accidentally or inadvertently accusatory. I'm not sure that's a deficit. It's just something they need help with. And one of the things I've done to help people understand what they sound like is to point out that the McLean voicemail system has a playback feature. And why don't you play back your message? And people have been astonished at what they're saying. And one patient said, it took me 11 tries to leave something that wasn't amazingly offensive. I had no idea that I was ranting and raving for the full 10 minutes and this and that. And it's like, there are lots of ways to teach people what they seem like in an understanding way. It wasn't like this woman was a bad person or she was wasting my time. That was the best she could do then. She can do a lot better today.
Well, thank you very much, Mary. We want to keep on going.